All this is Dr. Mobeen Sayed from drbeen.com. I am super excited. We have a rock star with us, Professor Dr. Hector Carvalho from Argentina. This is such an honor. I think now you know that whenever I have such rock star guests, I just cannot hide my excitement and my pleasure. So, Dr. Carvalho, welcome. Thank you very much for being with us.
Well, thank you, Dr. Mobeen. It's my pleasure. But if I'm considered a rock star, I should be Bill Haley, because I'm about his age, older than Elvis.
I see. So for us, you are a very young rock star. And thank you very much for your work, especially in Argentina, which is going through a hard time. Thank you very much for being a light in the darkness over there and helping. I had tweeted about you and somebody said, which was very interesting. They said, we wished, so I'm paraphrasing, we wish that your message was more prevalent in Argentina and they could use your expertise more. So I think that the world can use your expertise more. And so for the cool beans who are here, Professor Dr. Hector Carvalho doesn't need any introductions. He is a popular celebrity, a popular personality on the world stage for how to manage COVID. So his services are known. What I wanted to quickly do is to show you what his work is, so you can actually go and look at that as well. So first, here is Argentina, and we would discuss a little more about this with Dr. Carvalho. Here is, and so I can call him professor, I can call him doctor, I can call him a friend. So here is
how about calling me Hector?
Okay, I that would become very difficult for me to do when I have a celebrity and calling you with the first name. So I'm going to continue to call you Professor Carvalho or Dr. Carvalho. So here is his work on ResearchGate. And if you go to ResearchGate and look for Hector Carvalho, you would see 31 publications here and with their citations. So you can actually scroll through them. A lot of them related to COVID and other works as well. So please do me a favor, just browse through them and read a little bit of these as well. So having said that, once again, welcome. Let's start with this. So one more administrative thing for the Cool Beans here. Cool Beans, I would like to go over the management approach for COVID-19 with Professor Carvalho over here. Once we are done with that discussion, I would request you to then ask your questions. If you ask a question now, it will scroll past in the comments and it will be difficult for me to go back and find it. So please hold your questions for a few minutes while we discuss the management. In my opinion, Hector's management approaches are going to be a gift for healthcare professionals to understand how to manage various COVID patients in various stages of the disease. And so that is the agenda today. Professor Carvalho, how about we start from here? So I'm going to keep switching between Hector and Professor and Doctor. These are all your names. So how about Argentina? What is happening there?
Well, Argentina is in a very bad moment. So if I were one of the listeners, I would say, what is this guy talking about if his country is on fire? And it is on fire because the number of cases and deaths rises day after day. But the problem is that though we have been the second ones who worked with ivermectin in the world, and the first ones who published about ivermectin use against COVID, ivermectin has not been authorized in the country except for 5 provinces, which are not the most populated provinces. So the population of these 5 provinces account for less than 20% of the whole population of Argentina, which is 45 million people. So the rest of the country is not using ivermectin, maybe using it, but not officially. And that's a problem because they don't get the results that the other provinces have got. That's why Argentina is on fire in spite of ivermectin, because just a little part of Argentina is using it.
I see. So that is a sad situation. Unfortunately, not uncommon either. This is a situation that is happening worldwide in many areas.
Yes,
Um, Tell me this: did WHO's, and you can totally decide to pass on my questions? Did WHO cause harm when they came out and they said that ivermectin should not be used?
absolutely. And Dr. Pierre Corey from the FLCCC said it with all the words um, a few days ago. It's criminal what the sanitary authorities in the world have done, because by disregarding things that have been not only promising but absolutely effective, they could have I guess they could have prevented 500,000 deaths in the past year, and it's quite a figure. It's quite a figure.
Absolutely.
It's not a small figure. Uh, one life counts, but
Absolutely.
if you are talking about 500,000, it's quite a lot. And in Argentina, uh, at least from the 70,000 people who died, at least two-thirds could have been saved. But
That's
following the who is like a blind person following another blind person.
makes sense. Makes sense. So this is the sad situation. Now, if I wanted to go over your approach, so you have been managing, you have been doing research, you have been doing studies, you are publishing them, you have a publication coming out tomorrow as well. So quite prolific work in this area. So if you could be kind enough to tell us that how do you manage? So if I can start with various states of the patients and type of patients and see how you approach them, that will become a very interesting protocol for the people who are managing. So let's start with this, and you can totally say that, hey, I'm not working with this cohort. Starting from children,
Okay.
young age, under 19, vaccination plus management, how do you approach it?
Well, first of all, I have to confess I'm not an anti-vaccine guy. I've never been so. I have been gathering tens of thousands of dollars in order to have the African and the Asian population have them vaccinated against polio, because I'm pro-vaccines, provided they are serious, and provided they have proved to be either effective and safe. If they are not, I'd rather pass. And now they have been trying vaccines on subjects under 18 years old. I guess we have never said it's a matter of vaccines or ivermectin. We have always said it's a matter of vaccines and ivermectin. And we have been using ivermectin in children and grown-ups, of course. But and I can say that over 5 years of age, you can use it safely without no problem. Pediatrics use them in even younger children from 2 years on. We don't do that for two reasons: because we think it's too close to the age in which you don't have to use ivermectin. That's one reason. And the other reason is because these children, fortunately, have not been so affected by the pandemic. Maybe they can get the virus, maybe they will transfer the virus to other people, but they won't suffer serious cases of COVID, except for just a few cases of PIMS, PIMS, and Kawasaki syndromes. Except for that, children have been very seldom affected by this pandemic. Quite the opposite of the previous pandemic in 1918, 1919, that affected the H1N1 that affected mostly children and youngsters. This is not the case now. But I guess I wouldn't try to spread vaccines to all ages. I would try repurposing drugs in order to get the same effect but with less potential danger.
Totally agreed with you. Thank you very much for this comment. And I want to disclose my own position as well, so that the listeners here can be clear instead of trying to read between the lines. I am a pro-vaccine, very strongly pro-vaccine. I have gotten my own COVID vaccines as well. In
Mm.
addition to that, I have been for the last, I think, 15, 16 months. I have been talking about hydroxy to be effective, zinc to be effective, ivermectin to be effective, vitamin D's usage to be effective. So there are many, many ways to go about protecting yourself. And I believe that all of them should be engaged. And in addition to that, if you do not like any one modality in here, it is your decision to use that or not. And I also want to align with Dr. Carvalho for one more thing, and that is I feel hesitant for the children. This is, I know that this is a position that pro-vaccine, fully pro-vaccine, do not like, and I understand that vaccines are actually usually used for children. However, I feel a little hesitant or concerned when the children who may be at less risk anyways are also looked at for vaccination. So I think that is going to be a decision which is yours. I'm not going to influence it one way or the other. So wanted to, Professor
Oh, wait,
Carvalho.
because the fact is, no extreme is advisable.
Hmm.
Being anti-vaccine is bad. Being pro-vaccine for anyone, no matter what, is the other extreme, and no extreme is advisable. We must find something wise in between and attach to that. That's it.
Yep, absolutely. And just to add some examples to this statement that Dr. Carvalho, for example, in Netherlands, we saw that folks who were too fragile when they were given vaccine, they could not handle the side effects. So it is not the vaccine that caused their death, but still it was the side effects that their bodies could not handle, and they died. So eventually it became the vaccine that led them towards that. So that created a rule in Netherlands to say if somebody is too fragile, please don't give them the vaccine. Similarly, adenovirus based vaccines under 50 years of age for women have seen to be causing clotting. And so a different kind of vaccine should be used, or if this vaccine is the only option, then should be used with a complete protocol. So I think that is the kind of wisdom that should be applied instead of blindly anti-vax or pro-vax.
Doctor, sorry for interrupting you. This is my first time tonight, but not the last time tonight that I will interrupt you. I'm a serial interrupter.
That.
The fact is, um, when you get any vaccine for anything, whatever vaccine you want to mention, you have a chance to suffer some symptoms of the disease in a smaller way, in a lesser way, but some symptoms. When you get the vaccine for the flu, you may have a flu-like syndrome for a couple of days, and that's absolutely usual. But the fact is, one of the effects of COVID is clotting because of hypercoagulability. That's why the vaccine may also provoke clotting. It's not a matter of your vaccine provokes more clotting than mine. No, it's yours. It's a kind of fight between big pharma, and we are just in the middle of that fight. But the fact is that any vaccine may provoke clots. So that's why we advise to use aspirin from a week before getting the job, and at least 10 days, no less than 10 days after the shot, in order to reduce the possibility of suffering clots.
I love it so much. So the medical folks over here, you are going to get so many gems today in this talk from Dr. Carvalho that you can collect them and continue to practice saving folks with COVID with even more expertise. So thank you very much. I want to ask one more question. I'm going to try to call you Hector. Hector, I'm going to ask you one more question.
Okay.
For folks under the age of 19, ivermectin, vaccine, nothing. Do any other thing, supplements, any diets, any foods, any other protection? What is your advice? If I'm a 19 years old, and I would love to, and I come to you, what would you tell me?
Me too.
Yes.
Well, the fact is, all the compounds that you mentioned, all of them are good against COVID. All of them. It's not a matter of mine is better. No, all of them are good and they may be used together. The fact is that these compounds have no owner and are very cheap. That is the only problem they have in common. Problem, if you take it from the point of view of big pharmaceutical enterprises. But zinc, vitamin D, ivermectin, they can all go nicely together. And you may use it in many ages, even in children, because if you live close to the North Pole, you are going to give the children vitamin D because they don't have enough sunlight.
Got it.
And that's a
Absolutely.
fact. It's not a matter of today. It has been done. It has been done so for many years. So there are so many compounds you may use to reduce the chance of contracting the virus, because this virus, after all, is not as strong as they want us to think.
Got it. Thank you very much. And just a quick note here, Jim Metox, thank you. You're back. And I just saw your comment that you had an issue and you had been in ICU. So sorry for that. We missed you for last 2 weeks. I was actually kind of wondering what happened to Jim. Did he just stopped liking the channel's work? But thank you and welcome back. And I'm so sorry for what happened. Back to Dr. Carvalho. Dr. Carvalho, so now let's say I move to the next stage of the population plus the disease. So let's say I come to you and I say that I have a COVID patient at home and I was taking care of them. What should I do?
Well, that's a very good question. First of all, the WHO said in its guidelines that close contact with symptoms should be considered positive. That's nonsense. Close contact is positive, because if you wait till the symptoms appear, you have lost something you won't recover. You have lost time. So as soon as a patient is diagnosed, all his or her close contacts should be treated as if they were mild cases, even if they are asymptomatic. This is like lice. Hmm? If a child comes back from school with lice, you don't treat the child, you treat the whole family. Otherwise, you will never get rid of lice. And this is the same. You have to treat the whole number of contacts. And if that person works in a factory and he shares his working place with 50 people, you have to treat the 50 people, because you waiting for them to develop symptoms is like condemning them to suffer. And I far prefer to overtreat 100, 1,000 of persons, but not losing one more person, one more life.
Makes sense. So then my follow-up question will be, how do you manage the patients with mild symptoms?
Well, we have made some differences between what we used to, in the last year and this year, not because the compounds or the quantities we used the last year didn't work. They did work, but the fact is our enemy today is far stronger than the last year, because the variants, we in Argentina we have the Brazilian variant, the South African variant, the Oxford variant, and now the variant from India, and we don't have the one from California. That's the only one we don't have yet, but it's a matter of time. It's
I
just a
am
matter
from
of time.
California. I'm coming to meet
Well,
you.
it's a matter of time. It would have been the prettiest one because California is so pretty, but anyway, we don't have it. The fact is, the ones we have are far stronger, and what is worse, they pass from the viral time to the hyperinflammation time in a shorter period, not a whole week like the Wuhan variant, that the original variant. These ones just take 3 days, 4 days at most to get into the hyperinflammation period. So the fact is, you have to act promptly. You cannot lose time, because losing the time is in favor of the virus, not in favor of the patient. So we cannot waste time. And we give them uh, 0.6 milligrams of ivermectin, 0.6 milligrams for all the mild cases, per kilogram, of course, or 0.3 per pound, because a pound is roughly half a kilogram, mostly, roughly. And we repeat that on day 1, day 3, and day 5, depending on the condition of the patient, because we are talking of the ideal patient. Which is the ideal patient? The one that suffers the first symptoms and comes to see you. But sometimes they don't go the first day, just the second, the third, or a week later. So they are mild, but not just in the as they have started. They have lost time. So in those cases, we use it in 3 days, 1, 2, 3 days, one after the other. So we personalize the treatment according to the severity of the symptoms and the comorbidities of the patient and the time in which the patient is seen, how soon or late he has been seen. So early treatment now has to be divided into these 3 categories, something we didn't do the last year. Now we have to do it. I'm fond of boxing. I've never been a boxer, but I like to see the boxing
Matches.
matches, and there have been some champions that, in order to go to a higher category, have to gain weight and behave in a different way. So we have done that in order to go to another category, to have other challengers. We have to gain weight. So we have to go a little bit further with the amount of ivermectin that we used last year. We have to double it this year.
Got it. So very interesting. 0.6 milligram per kilogram body weight, day 1, day 3, day 5, or consecutive days, depending upon the severity of the patient and the state. Dr. Carvalho, do you add anything else as well? Do you do
Yeah,
budesonide, for example, or what
we
else is there?
we never try to foster the idea of a silver bullet. We have always used the compounds in a combo. For the mild cases, we use ivermectin and aspirin, provided we can use aspirin. And we give 200 milligrams per os every day for at least a fortnight. in these patients. In order to reduce as we do with the vaccines, in order to reduce the chances of developing hypercoagulation. If the patient is a little bit not mild but moderate, we add corticosteroids. You may say, well, everybody does it because corticosteroids have been proved all over the world that they really work. Yes, but we have been using it since early March last year, before the Oxford trial appeared. We have been using that, and in those days it was a kind of a sin to use corticosteroids. But it was clear that you had to use it. You cannot treat hyperinflammation without corticosteroids. And in the severe cases that had to be admitted at the hospital, we changed aspirin for heparin. And that's the way we do it. Instead of preventing the platelets from aggregating, we prefer to use an anticoagulant.
Got it. So very, very interesting. So ivermectin plus some anticoagulant, even in the mild case, and then of course moderate and severe cases as well. Any oral steroids, budesonide-like things?
We don't. We use the. It's a good question. We have started using budesonide, but not for the patients during the infection, but after that, not in the convalescence precisely, but for the people who develop sequela. Something that we have previously talked about, not for long COVID, not for long convalescence, but for the people with lung sequela. We have diminished their capacity of breathing, and we use budesonide in a spray, but not earlier, not in earlier stages. We don't say that it is not wise to use it. We don't use it.
Got it. And
But
the
the best combination is the one that works for your patients.
makes
That's the
sense.
best one.
Makes sense. And to the cool beans here, this will be a fascinating talk in a few minutes, that what are the COVID sequela versus COVID long haul and how to approach them. So I'm going to go there in a few minutes as well. I want to dig a little deeper on the mild and moderate side as well. So now we have anticoagulants, we have ivermectin. Do you stress on a need to understand their vitamin D levels, or do you say that, hey, take supplements, or how do you approach that? Do you even bring it up with the patient? Do you get them tested for it, or not important?
I didn't quite get the last part of the question.
So the vitamin D, vitamin C.
Yes. Okay.
How
Yes.
do you approach that?
We haven't used it, but not because we don't believe in its usefulness. It's just because we didn't want to increase the quantity of things we were using. We are because no extreme is good. We have already said that. We don't believe in a silver bullet that is one single compound, but we don't want to use 10 compounds altogether because it's difficult for a patient and his family when he's treated at home to remember all these medicines all together. So the smaller the better. That's what we think. But we do know that those compounds are useful. We do know that.
Got it. So you have for a compliance reason, you have a minimum essential or critical set of substances, drugs,
Yes.
medicines that you feel
Yes.
must be given, and that is how you start with them.
Yes. For mild cases, we use ivermectin and aspirin, and we are adding now bromhexin. Is it well pronounced?
Yeah,
Bromhexin.
bromhexin, yes.
Bromhexin, which is older than me, but in fact, it has proved to be very good in order to block the TMPRSS2 receptors that are the key for the door that the virus uses to enter the cell. So we use that for the mild cases. In the mild to moderate cases, we start thinking of using corticosteroids. We always prefer dexamethasone, but the fact is, if it is injectable, apart from the medicine, you need the nurse, and nurses are not always reachable. So in those cases, in mild to moderate cases, we prefer methylprednisolone because it may be given per os, and you don't need injection, and you don't need the nurse to go to your house. But when the patients are admitted at the hospital, we do change to dexamethasone, and as I told you, instead of an antiplatelet compound like aspirin, we start using enoxaparin.
Got it. Got it. Thank you very much. And talking about bromhexin, I want to quickly thank Arubaga here, who is also a cool bean. So he lives near my home. And when I was sick, he had bromhexin and he asked me to come pick it up. So, Arubaga, thank you very much for the bromhexin gift. Dr. Carvalho, so we cool bean are a very closely knit and very well informed and educated group here. I love it. So tell me this, Dr. Carvalho, the COVID sequela versus long COVID. What are these two things? You were saying that people, doctors, have mixed them together and lumped them as one unit, and they should be treated and looked at separately. Tell us, what are these two separate things?
Well, when we started trying to divide both things, we put them all together as post-COVID, and then we tried to divide it into long COVID, that is long haulers, long convalescence, and COVID sequela. And we found it hard to divide them because there are so many things that they may have in common. But the fact is, it's a matter of definition. A long COVID is long convalescence. It's something who suffers the symptoms, but sooner or later he will get rid of it. Hmm? The brain fog, the hypogusia, hyposmia, and the tiredness. He carries that, he suffers that, but sooner or later he will get rid of it. But the sequela is something that will remain with the patient and may reduce his capacity to live a life that's full. Because if I get a patient, a 30, 35 years old patient, and after surviving COVID, I find that he has developed pulmonary or lung fibrosis, and I have to tell him that in a couple of years he will have oxygen. He will need oxygen to do his daily life. That's terrible. That's terrible because he has put a mortgage on his future forever, and he won't be able to pay for that mortgage. And those are the sequela. The sequela may be neurological because of strokes, maybe cardiological because of infarctions, and maybe respiratory because of fibrosis. Those are the sequela. And they have to be treated as any sequela, as something that will remain with the patient, that maybe you won't be able to retain, to get the patient out of the problem, but you have to gain time, to give time to the patient to reduce the progression of the sequela as far as you can. And that's when we use, for instance, for the lung fibrosis, budesonide, together with exercises, together with bronchodilators or anticholinergic aerosols, and fluidificants, the ones that make the mucus more fluid. That's what we use for the sequela. not for the long COVID. For the long COVID, we may use ivermectin if it had not been used before. But the truth to tell, you may have seen, Dr. Mobin, that if you use ivermectin, you won't have long haulers.
This one statement. So, folks over here, you can cut out the whole interview before and after, and just take this one statement of Dr. Carvalho, and that is the golden nugget for the whole population. If you're treating patients early aggressively, how with ivermectin, you actually don't end up having long haulers. You don't end up having even people with much sequela, because they are going to be recovering with much better outcomes.
Okay, that's correct. But maybe you will have to handle patients, to treat patients that have survived COVID, because there are plenty of them, without ivermectin. In those cases, you may use ivermectin for the post-COVID, for the long haulers, together with vitamins and some supplements. You say
Yeah,
supplements?
yeah. Supplements,
Supplements,
vitamin D, and yeah,
like the ones, not hormones, but vitamins, polyvitamins, and the supplements that those people who to practice sports and wrestling, and, well, you may use them in order to reduce the period of long convalescence. And you may reduce it to a half, which doesn't seem to be much. But if you are going to suffer a long COVID for 3 months, and you are told, and you may sense that it will last just 45 days, is quite a progress.
absolutely, absolutely correct. And just to add one more statement here, a few days ago, I had tweeted that there are two prophylaxes for COVID. One is a prophylaxis for COVID itself, the acute disease, and that is ivermectin. The second prophylaxis is that if somebody has the disease, you have to prophylax them from long COVID. And that
Yes.
also is ivermectin and maybe even steroid at some point. This is how critical and crucial ivermectin is. And vaccinated or not, ivermectin has a very important role in managing patients of COVID. Two prophylaxis, which are done by ivermectin.
Mhm.
So, Dr. Carvalho, thank you so much. So, for the cool beans, today we have one more idea here, that those who are post COVID, they may suffer from the COVID related damages that may become chronic with them. Pancreatitis causing diabetes, lung fibrosis causing shortness of breath and the lung issues, strokes, cardiac issues, and so on. So that is a sequela, and their treatments is dependent upon what is the sequela itself.
Mhm.
And then there is long COVID. I'm very, very much fascinated with the long COVID. So can I conjecture, and please confirm, that with your management, you have seen in your own cohort of patients, you have seen very few long haulers?
Well, yes. For those who were treated with ivermectin, we have been almost no long haulers. But for those patients that we received after surviving COVID without ivermectin, because there are lots of them, um, we have treated 853 patients which were long haulers, and we saw that we could reduce the period of suffering, this long convalescence, to roughly a half.
And your total regime for long haulers, for example, for my the situation is very similar to me as well. My own patients that I start managing from the beginning, out of all hundreds of them, there are just three that became long haulers. And
Mhm.
one did not know that she's a long hauler, so she didn't even talk about it. The other two I identified right away and managed them, and they became healed within a week or two. And the third one, who reported after a year, and now I'm managing her, and she's actually very happy with ivermectin. Uh, but then there are folks who were treated differently from other doctors, and now they have long haul. I want to ask you this: for long haulers, in addition to ivermectin, do you use anything, steroids or fluvoxamine or antihistamines? Do you have, what is your uh, cocktail? What is your prescription possibilities?
Our combo is ivermectin and multivitamins, and hydroxymethylbutyrate. I don't know how to pronounce it in English. Hydroxymethylbutyrate, which is a compound that is used to prevent sarcopenia and osteopenia, which are two things that you may see very often in the post-COVID.
Very interesting. Very interesting. So thank you very much. If you allow me now, I'm going to take some of the questions from Cool Beans as well. We are 43 minutes into the talk. I know it is your night, it is after your dinner. Did you have a good dinner, or are you going to have a dinner
Well,
after the talk?
just a brief one without alcohol in order to be able to answer as many questions as possible.
Got it. Thank you very much for doing that, for that sacrifice today for us. So, Cool Beans, how about we do this? Let's ask some questions from Dr. Carvalho as well. I'm going to look at the Twitter thread as well that was there and see if there are any questions there. And I'm going to ask the live audience as well. So, give me 1 second to set up my questions. So, Dr. Carvalho, I'm going to open up Twitter here as well. And there are some questions there too. So let's start from there. Here, there is a question from N and G, and they are saying, any studies finished for ivermectin and long haulers syndrome yet from you and your team?
Yes, we have published two studies, one for long COVID, which I may send all the articles, because one of the things I wanted to say, you may find all the articles in ResearchGate, but that doesn't mean they are not peer reviewed, because we have published all our articles or our trials in peer reviewed journals. But apart from doing that, we included them in ResearchGate so that the more people can benefit from reading them, if they want to do so, of course, and not depending on being a regular reader or having paid for the magazine in order to have a subscription. So we put them in the both areas, and we have two studies on the first one on long COVID and the benefit of ivermectin in the long haulers, and the other one who will be released tomorrow, and I promise I will send it to Dr. Mobin as soon as it appears in the Journal of Pharmacology and Toxicology. That is that we are differentiating conceptually and clinically, differentiating long COVID, long haulers from COVID sequela, and how we treat them. And those articles have already been released, and they are not theoretical. We are not talking theoretically as if we were giving a lecture from a desk. We are talking about our own patients.
Very good. Thank you very much. Jonathan Loon says, case counts are rising sharply again in Argentina. What is the situation with the government with adopting the use of ivermectin and iota-carrageenan for the early treatment and prevention of C19?
Define government.
Okay. So
that's the answer. That's the answer. We have vaccines just for 10% of the population, and they were used in the members of the government party instead of being used in the old people. So I'd rather not talk about that, because it makes me mad.
Got it. Thank you very much for that question about definition of the government. Honor Barnes UK says, fabulous news, his brilliant one-liners, which we are all fan of. Question, in what form did his study use carrageenan, please?
Well, carrageenan has been used, first of all, when we presented the first two trials a year and 2 months ago to the National Library of Medicine in the United States. One was for treatment, the IDEA trial, IDEA because of the acronym of ivermectin, dexamethasone, enoxaparin, and aspirin, not in that order, but it sounded better, like IDEA. And the other one was the Ivocar because it was ivermectin and carrageenan. Carrageenan may be used either as prophylaxis together with ivermectin or alone. We prefer to use them together. But the fact is, you have to be careful with those patients that cannot receive ivermectin. For instance, those who have a proved condition of allergy to ivermectin, the pregnant women, lactating women, and children under, say, 5 years old. In those cases, you may use carrageenan alone. It is a topical spray. It is available all over the world. The main producer of carrageenan is in Austria, and it is sold all over Europe. And they have made some pretty studies in Austria with carragellose, as they call it, and it may be used on both nostrils and inside the mouth in the morning, in the afternoon, and in the evening, in order to prevent the virus from entering. It creates a barrier which is very difficult for the virus to surmount, and it's very good as a prophylaxis. We don't say use carrageenan, don't use the masks. We don't say that, because the more protection you have, the better.
Got it. One more question, and again, you can totally say pass. So, Honored Barnes has one more question, and that is who at WHO is using ivermectin? So, her context is he made a comment alluding to this once. So, do you know someone in WHO using ivermectin?
I don't exactly know, but I wouldn't be surprised to, because even in Argentina, those who don't authorize ivermectin are using ivermectin, and I know that. I know the persons who are using them, and I wouldn't be surprised if people in the WHO were using it. I wouldn't be
Got it.
surprised.
Got it. So there are a number of just some posts as well about the um, clotting, unfortunately, a death there. So I'm going to now switch to some of the questions from YouTube. So let's see what we have on the YouTube side. So right here, Rima, have you found that people with blocked nasal passages due to thick nasal mucosa will be less at risk or more at risk? So somebody with nasal congestion.
Well, I don't think that a mechanical barrier is good enough to stop the virus. For instance, if you have a trench during the First World War, if you have a trench, but an empty trench without soldiers in it, it was just something they could jump over. So a mechanical barrier is not useful as a chemical barrier. So I wouldn't say that having that problem is enough not to contract the virus. I wouldn't say that.
Got it. Thank you very much.
It's the same like saying that if I have a bigger nose, I am more more. I have
Prone
more
to-
possibilities to contract the virus.
Got it. Got it. So there is another question from Random here. He's saying, I have COVID now. I'm almost fully recovered with mild symptoms after 12 days. Do you recommend vaccination for recovered people? I am from Cordoba, Argentina.
Well, we have encountered some issues in those patients that were recovering from COVID and then they got their vaccines. I think that they should wait at least 45 days after recovery, and if possible, because not always is possible, they should have their level of antibodies checked. If it is high, they don't need the vaccine because they have already had the best vaccine ever. That is, they have suffered the disease and they have lived to tell it.
Got it. Got it. Thank you. Sharon says, question, use of rivaroxaban in post-COVID period. So have you used rivaroxaban?
I have no experience in rivaroxaban.
Got it. Next question.
That doesn't mean I disrespect rivaroxaban. It means that I don't have experience.
Got it. Thank you. Arubaga. So we were talking about Arubaga a few minutes ago about bromhexin. So his question, is 12 milligram per milliliter iota-carrageenan high enough concentration for COVID prevention?
I think so, because the concentration usually is a little bit less than that. It's 8 milligrams and it worked. So 12 should work. Absolutely.
Got it. Thank you. Eileen Glazer Miller says, thank you, both doctors. Do you either doc or both of you recommend quercetin with ivermectin prophylaxis?
Well, I have not used quercetin. No.
Got it. And so my part
once again, I don't say I have used it and it didn't work. No. I haven't used it. That's why I couldn't talk about it. It would be wrong for me to talk about something that I haven't not used.
Got it. And my part of the answer, I always use zinc and quercetin, if not hydroxy. So even this morning, there was a patient who called me and I was managing or having them write down their prescription. And part of that was quercetin and zinc as well. So wherever quercetin, there are some places where quercetin is not easily available. For them, I say that, hey, eat red apples or berries or vegetables with red skin, but I use it. Next question from Rudy. How many patients have you treated? Have all recovered successfully?
Well, I would say that I stopped making a list many months ago, but I'd say that directly or indirectly through other doctors, because we are a team, we have treated over 15,000 patients, which is a figure. And for instance, this morning I was talking with very brave medical doctor in the province of Salta who has been using ivermectin since the very beginning, and he's treating more than 100 patients per day, 3 days a week. That is more than 300 patients in a week. That is more than 1,200 in a month. And in the last month, with ivermectin, in the last 3 months, he had to refer to the hospital just one patient.
Wow.
Out of 1,200.
Wow. Beautiful results. Thank you for sharing that. Next question, Samina. And on Samina's behalf, I will actually ask you 2 questions. So one question that Samina asked very commonly, and she herself is a physician in Bangladesh. She asked that, how do you manage pregnant women who have COVID? So I'll ask you that question. Plus, she has a question here that comment on IMath protocol from Dr. Paul Marek. And you have appeared with Dr. Paul Marek and FLCCC many times. So 2 questions, whichever you want to answer first.
Well, the first one, I think we have already answered that. In pregnant women, we don't use ivermectin. We may use carrageenan because carrageenan has been present even in the maternalized milks for years. So even if it passes through the milk, it won't damage the baby. That's why we prefer to use just carrageenan, and may use vitamins too, but not ivermectin. And then from the IMATH protocol, I don't think I should talk about a protocol that doesn't belong to me, but the protocol from Dr. Paul Merrick and all the members of the FLCCC are really good, absolutely good. We have taken things from one another. That's the truth. With Dr. Pierre Corey, mainly, we have taken things from one another because it's something so elementary, so elemental. You have to copy the things that work, and you have to avoid the things that don't work. It's that
Makes
easy.
sense. Makes sense. Next question is, and thank you very much for giving us your time and insights. Iggy Pop says, what is Dr. Carvalho's biggest concern about current mRNA vaccines?
That's a tough one. This is a completely new world for us. This is something we are facing for the first time in our lives. We knew that it would be a matter of time to have this kind of vaccines, but we never thought it would be such a short notice. And I think that maybe they need more research.
Got it. Got it. Thank you very much for that as well. I'm going to ask next question. 1 second. I just became computer challenged. Sorry. So back here. So the next question is from Liza. Liza says, how is Sputnik 5 working in Argentina?
Well, that's something not easy to answer. We have had reports that patients, but not one or two, but many patients that had their antibodies levels tested after the second jab of Sputnik, and they didn't develop antibodies. We may say that this is because of cellular immunity instead of humoral immunity. Maybe that's the reason. But the fact is, we didn't see any movement of the antibodies, any rising of the antibodies in blood in many patients, and that's a matter of concern. And besides, um, I will say something that may sound childish, but I guess all the listeners will understand it. If I go to get my annual vaccine vaccine jab against the flu, and the pharmacist says, I have run out of the vaccine flu, but I have some from the previous year, I would say, no, I want this year version because I want this year variant. Is that okay? So many of the vaccines have been prepared for the original Wuhan variant, and they have been prepared with parts of the spike mounted on an adenovirus from monkey, from the kidney, from whatever. But parts of the corona, parts of the spike. Now, the new variants have introduced modifications in the corona, in the spike. So some vaccines may not recognize, or the immunity caused by those vaccines may not recognize this variant. That's what happened in South Africa. South Africa developed the South African variant, and the vaccines proved to be just 10% successful if compared with the 95 or 98 percentage of success that was expected. So for new variants, you have to have new solutions or new alternatives.
Got it. Thank you very much for that answer. One more question, and please tell me when you say, you know what, enough, because there are questions. There is a question from Logic, and the question is, Dr. Carvalho, why does the dose of ivermectin keep rising? Are variants getting stronger, possibly bypassing ivermectin eventually?
Well, I guess I have already answered that. We didn't expect the moment when ivermectin, of course, and part of the question is absolutely right. The virus has become stronger. The variants are more lethal and more contagious than the original one. So the answer has to be equally stronger. Well, we didn't expect the moment in which we had to concede that ivermectin dose wasn't enough. We increased the quantity we give just to avoid that moment.
Totally makes sense. And if I may, for a second, Logic, look, the basic thing is this. Let's say there are 3, 4 cells, and we have the original variant, and that comes in, and the binding affinity with the ACE2 enzyme is, let's say, 10. And so what happens is, out of all these 4, and they all have hundreds and thousands of receptors on them, maybe some viruses, 10 of them can enter a cell, and the rest are still struggling with it. So if we have 10 molecules of ivermectin, they can probably block those 10. But now what is happening is, because their binding affinity has increased, they have a better chance of getting into the cell faster and more. So we have to create a higher density of the drug as well, to stand at more and more doors to protect from these viruses to enter. So I don't think that ivermectin will become defeated by the virus. I think that this kind of a dose would actually continue to work with it. So sorry, Doctor. Sorry,
No,
Hector. I just
but you're absolutely right. It's like a patient that undergoes a lot of plastic surgeries. He may look different, better or not, but different. But if he was allergic to cats, he will keep being allergic to cats. If he had um, as I say, a neurological condition, he will keep having that condition. If he visited his parents every weekend, he will keep doing that every weekend. He looks different, but he's the same person. That's why ivermectin keeps working. We have increased the quantity we use because the enemy is stronger, not because it had failed. But it keeps working. But what you say about the general aspect of the virus which has changed is the one that challenges some vaccines.
absolutely correct. Next question from David Scully. Do you think the Argentina media are ignoring you and ivermectin?
Uh, well, I don't care about media. I know that the patients are not ignoring ivermectin. Well, I don't mind if they ignore me. I'm not I'm not important. The idea of using ivermectin is what is important, and patients are doing that. But sometimes I have to concede that they get the medicine on their own and they use it as well as they can, and that is a problem because they don't receive the proper suggestion in which to use it, and that's a problem.
Got it. Colin Hummel says, was ivermectin used against dengue fever in Argentina too? If so, was it effective?
We have no time to. We were going to, but when the pandemic broke,
Got it. Got it.
we were going to do that because ivermectin had proved to be effective for dengue fever and Zika fever and chikungunya fever, which are endemic in this part of the continent. And we were thinking of using that together with doctors from Singapore, from the Duke Nas University. But then the pandemic took all our attention.
Got it. So next is a very interesting question. Bilal from New Jersey says, did Professor Hector treated any vaccinated long haulers or vaccinated haulers yet? If not, what does he think about those who suffer from vaccine symptoms for a long time?
Yes, we have received some patients who have complaint of suffering the symptoms after being vaccinated and not before. And we use ivermectin in those cases. We never use ivermectin in the very same moment that the vaccine is administered, because we don't want to interfere with the vaccine they are receiving. We at least wait 10 days after being vaccinated in order to start ivermectin if they need so. But with that period of safety we have considered, we have kept, we have used in post-vaccination patients without any problem, and they never became long haulers or long vaccine holders.
Got it. Thank you very much. Couple of more questions. One question is from Denise. Do you prophylax your patients with ivermectin? If so, what dose?
Yes, we 0.2 milligrams per kilogram. Remember, I'm always talking about kilograms. We don't use pounds in Argentina. You have to make the conversion. 0.2 milligrams per kilogram once a week. That's what we do.
Got it. Thank you very much. And one last question. Random says, do we have cases of black fungus in Argentina? Could ivermectin help to prevent it?
I don't think ivermectin is so miraculous. We have had a tradition of thinking that when one medicine proves to be right, it has to be right for everything, and if it doesn't, it is good for nothing. So we go from one extreme to another. I haven't tried it in black fungus or mucormycosis, which is something which is usually found in post-COVID. We haven't used it.
And just to add to Dr. Carvalho, no, ivermectin is not going to help with that. So please don't. Mucormycosis is an emergency. Every minute counts because it can get into the bones and it can really cause disastrous outcomes. So just be very, very quick with the antifungal treatments.
That's correct. That's correct. So that's why I say the fact that we have found that ivermectin is good for COVID doesn't mean it's good for any disease in the world. For instance, it has proved not to be right for stupidity, and we wish it was good for stupidity in Argentina. It's stupidity from the government, I guess, and it wasn't good for that.
It has not worked. So I said that was the last question. I think two more questions. So Rima says, is ivermectin likely to work against other upper respiratory viruses? Also, if you had fought the wild virus, would you get vaccinated? If yes, why? So two questions.
Yes. Well, if upper respiratory viruses are sensitive or sensible to ivermectin, it could be useful. We haven't had time to try it in many different viruses. As a matter of fact, we have just used it in COVID because we had no time. We wanted to use it in dengue virus, which is not a respiratory virus. It is a flavivirus. But anyway, we wanted to do that when in the moment of the outbreak of the pandemic. So we had no time to prove in any other virus. And the second part of the question was...
So if you were infected by the virus itself and have recovered, do you think you still need a vaccine, or do you think you are protected? I'm paraphrasing Rima's question.
That's a good one. You know, immunity may be divided into natural or artificial. When it is active immunity, I am not talking about passive immunity like the one that's transferred from mother to the fetus. Not that. I'm talking about active immunity, may be divided into natural or artificial. Natural is by suffering the disease. Artificial is by receiving the vaccines. The most effective of all kinds of immunities uh, traditionally has been natural immunity. But for a potentially lethal condition like COVID, uh, letting the patient suffer it without trying to protect him is quite dangerous. So if he has developed antibodies in a quantity that is reasonable, there shouldn't be any need to be vaccinated. But for that, you have to wait 45 to 60 days after recovering from the disease in order to find out if he has developed antibodies. The fact is, some patients don't develop antibodies, even if they have suffered the disease. So they have to be vaccinated.
Got it. Thank you very much. One last question, and then I
No
promise
problem.
we'll
No
stop.
problem.
So Jody says higher ivermectin dose for prophylaxis, for new variant, and once a week. Thank you, doc. So is that what you would suggest for new variants? Higher ivermectin dose for
No,
prophylaxis?
no. We haven't changed the dose for the prophylaxis. We are using the same. That's something we have not changed. We have
Got
changed the quantities in the treatment, but
it.
not
Got
in the prophylaxis.
it. Got it. One more question.
No problem.
So Jody says, have you seen breakthrough vaccine variants? Thank you.
Breakthrough vaccine. I don't quite understand
I
what it
mean, have you
means.
have you encountered patients um, who may have variants that were caused because they were vaccinated, and their vaccine, even after vaccination, they became infected?
Yes, there are many patients who have become infected after being vaccinated, and that means it may mean two different things. One is that vaccine has not been effective, or the other one is that he has encountered a new variant for which the previously used vaccine was not effective.
Got it.
Those are the two possibilities. We don't have the resources to go that far,
Got
but
it.
we do have many patients that, after having received the 2 doses of vaccines, have developed the disease.
Got it. And one more question. Dr. Samina says, please comment on COVID vaccine in pregnancy. So
Well,
do you suggest
that,
pregnant
that
patients?
that's a question for the vaccine producers, not for me. Hmm? I,
Got
I
it.
don't I don't think it's it's the right moment to try it on pregnant women, as it is not the right moment to try them in children.
Got it. And I'm just going to make a comment here. Mr. Doc Griff says, I upgraded my Mac and lost my Bean moniker. So sorry about that. I was actually thinking about Roman and Dr. Griff Bean to say, I have not seen them for some time. So thank you very much. One more question, Dr. Carvalho, Hector. What is your view on ADE,
Define ADE.
antibody dependent enhancement?
Well, um, as I told before, we are not completely sure if it is a matter of humoral immunity or cellular immunity. We are mastering up resources in order to make a study of those patients, uh, 50 patients who have been fully vaccinated and 50 patients who have received ivermectin for prophylaxis for over a year, in order to study the cellular immunity. Because we believe humoral immunity is not regular, is not consistent, is not safe. I guess it must be a matter of cellular immunity. The other one is something we cannot trust on completely.
Got it. So with this, thank you very much. I know that I said about 6 questions ago that that was the last question. Thank you for being patient and continuing to answer those questions. Thank you for being here as well.
Okay, it's not so late in Argentina. Argentinians are used to go to bed very late, and it's not even midnight. It would be worse if we were in Australia. And but Australia is down under. Argentina is just down. So
Got it.
thank you for your patience, and I promise I will send you all the articles if somebody asks you about the articles tomorrow morning.
Thank you very much. I will tweet them out and I'll put them as a post on YouTube as well. And there are many, many cool beans here who are saying, will you like to return as well? Would you be able to come back if we invited you again?
If you're not tired of listening to me, I have no problem.
We can listen to you all day long. So, so thank you very much for being here. Cool Beans, thank you very much for your time as well, for your good questions as well, and for learning and keeping yourself and the people around you safe. Thank you for being with me in this journey as we learn more about how to handle COVID. Thank you very much, and I would see you tomorrow.
See you. Bye-bye.